Hello everyone and welcome to our webinar. Today's webinar is Common Part B, Physical Medicine and Rehabilitation Rejections and Denials. I am Mary Milko. I'm a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. I'm joined by my teammate Tom Ryan, who will assist with some behind-the-scenes help. Now, today's webinar is for those people who are wishing to learn about the most common rejections and denials on Part B claim submissions for Specialty 25 physical medicine and rehabilitation providers. CMS requires the MACs, the Medicare Administrative Contractors, to include this education in order to prevent future claim rejections and denials. And just as advertised, the information that I've prepared to present today in this webinar is based on actual claims data. The presentation is available for download from our live events webpage. The page address is in the chat. You may take time to download it now if you've not already done so. We will record this session, and barring technical issues, we'll post the recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current or until we otherwise decide to remove it. If you have questions, please place them into the chat. I will answer questions as time permits, but if I don't get to your question, I will email the response following the webinar. If you have a question on a specific claim that is actually processing now, or one that's been denied or otherwise already sent to Medicare, I won't be able to answer questions relating to that specific claim. You must contact customer service so they can access the claim edit trail in the system in order to provide answers for you. We include this disclaimer in all of our events. This presentation is for educational purposes only. I did make every effort to verify the information that I'll provide is current and accurate, but it is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings are those that will always prevail. CMS prohibits recording of this webinar for profit-making purposes. For that reason, and because we're recording this webinar for playback later, we ask that you not record the presentation. Here is our agenda for today's webinar. This is exactly what the advertisement read. Today, my goal is to share with you the most common reasons for rejections and denials for physical medicine and rehabilitation claims submissions to WPS. I will define rejections and denials. I plan to reveal the reason for rejections and denials based on the data that I pulled and analyzed, and I'm going to discuss ways to fix and avoid these. Along the way, I'll be providing you with many resources. This is a lot of information. In 60 minutes, I'll be moving quickly through the slide deck, and I may ask you to review some of the information following the live presentation, such as that list of resources that I'm making available for you at the end of the slide deck. Now, based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I have included this CPT copyright notice in your presentation materials. Your continued participation in this presentation does infer that you agree to the terms of this copyright notice. Now, in order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process. Now, based on a law that requires it, most providers are going to submit claims electronically. It's mandatory. When submitting claims to WPS, reports generate to confirm the claim receipt and report more specific information about the data requirements. Now, one of these reports is the 276-277 report. There is a companion guide. You can see the link to it here on this slide. It's the Medicare 276-277 Companion Guide. And this was prepared by our Electronic Data Interchange, or EDI staff, and it helps submitters understand the claim requirements and know when they need to correct or resubmit the claim. Now, claims that move past the pre-pass edits will generate a remittance advice. Sometimes we refer to this as the RA. Some folks talk and refer to it as the notice. There are two formats for the remittance advice: the electronic remittance advice, or the ERA, and the standard paper remittance, or the SPR. Now, with very few exceptions, most providers are going to receive the electronic format. The RA provides important information to the provider. For adjudicated claims, you can find a lot of information on the RA, information about adjustments and denials, even missing items and refunds, and sometimes even offsets. Now, when looking at a remit, you will find various reason and remark codes. These are typically in an alpha numeric format. When claims pay differently than billed, a claim adjustment reason code is going to appear on the remittance advice. Sometimes a remittance advice remark code will also appear, and these remark codes expand on those details described by the reason code in order to provide more details about the adjustment made. Now, another type of code that appears on the remittance advice is a group code. Group codes assign financial liability for any unpaid balance on the claim. A CO stands for contractual obligation, and this means that the provider is liable and can't bill the patient. A PR group code means that the patient is financially responsible. Now, WPS hears a lot of comments from our providers about these codes. Providers often state that the codes are too cryptic or that they contain outdated acronyms. While we'd really like to help, it is another contractor, not WPS, that maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to suggest a change to any of those code lists, including the code explanations. Since WPS is unable to help, it needs to be done by the Washington Publishing Company. Now, this slide shows a side-by-side comparison of rejections versus denials, and I think it's really important that you realize a rejection is very, very different from a denial. There are different actions to consider, and we'll talk about those during this presentation today. A rejection is deemed as unprocessable. This is what CMS calls them. They are unprocessable. They're returned on the front end. The reason is that there's something that's invalid or incorrect. It's missing. There may be incorrect information on the claim. For rejected claims, or those that are unprocessable, there are no appeal rights. You need to resubmit the service. You will see a remark code MA130 on that particular remit that will provide you with notification that the service is unprocessable and you need to resubmit it. Now, there is a typo on this particular slide. It is on the fifth bullet on the left. That's CO15 should read CO16. So please make a note of that. A CO16 is the group code that states that the patient is not liable. So that's what you're going to find on the remittance advice for a rejected claim. For a denied claim that's actually adjudicated by WPS, the remit will tell you that the service is denied because it failed to meet payment criteria. Maybe there's a law that states Medicare can't pay for that item or service. Those are statutory requirements. Perhaps the claim or the claim line failed to meet medical necessity guidelines or requirements, and this would include any utilization parameters or frequency audits or edits. Those claims that fail these. Other reasons a claim may deny is due to eligibility. Sometimes it's eligibility of the patient or the beneficiary, and other times it could be eligibility of the provider. Now, for denied codes, your remittance advice will typically, not always, but with few exceptions, show an MA01 Remark code. And this is a code that provides you with appeal rights. Again, I want to stress that while most denied services will show this on the remittance advice because there are appeal rights, there's a few exceptions where there is no appeal right for a denied claim. And of course, for denied claims or claim lines, the patient liability will be determined. So during the next few slides, then I'm going to discuss whether you'll need to correct or appeal the claim. After reviewing that remittance advice, you're going to need to choose the correct action. I mentioned earlier to you that to recognize the difference in a rejected claim versus a denied claim really helps you understand those actions that you can choose from. For an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. Now, if the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the claim or that service. You might be able to use the clerical error reopening process. This is a process to fix clerical errors, and CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors. Another action to consider is an appeal. The remittance advice will provide appeal rights. I'll discuss appeals a bit later in this webinar. Now, registered users can use our SecureNet Access portal. We call this SNAP for short. That's the acronym. They can use SNAP to render or request a clerical error reopening, or to request an appeal. And this is just one of our self-service tools, and these tools really do offer the most efficiencies. We have a portal user manual that provides illustrations and step-by-step instructions on how to use these portal features, those for our SNAP, SecureNet Access Portal. Now, for claim denials, most often, with few exceptions, you can request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. There are 5 levels. Only the first level is rendered by the MAC or by WPS. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MACs. The beneficiary or their representative may request an appeal on any service that's processed for them. Providers and suppliers may appeal services for which they accepted assignment, but for unassigned claims, providers and suppliers may act as the beneficiary's representative, but only if the beneficiary signs an authorization statement, such as the CMS 1696 appointment of representative. Now, in addition, providers and suppliers may request a redetermination on an unassigned claim, but only if Medicare denied the service as not reasonable and necessary, or in those cases where the provider or supplier billed in excess of the limiting charge. And of course, in that case, the provider or supplier would need to refund any fees collected from the beneficiary. As mentioned, the first level of appeal is the redetermination, and it is the only level of appeal that is rendered by the MAC. Time frames apply to each level when submitting appeals. Additionally, there's a minimum amount in controversy that applies to level 3 and level 5. You can combine like denials on more than one claim in order to reach that amount in controversy. You can check out how to appeal a claim determination on our website for additional details about those 5 levels of appeal. We also have some great YouTube videos available on our YouTube channel that you might wish to take a look at if you're looking for information on claim determinations, or how to appeal them rather. You can also consider using the CMS fee-for-service appeals process flowchart. I like to mention this to learners when I'm talking about appeals. It's one of my favorite CMS resources for appeals. You can see on the right hand side here a look at the 2024 version, CMS has since updated this chart to reflect amounts for calendar year 2025. But this actually shows those 5 levels of appeal. The MAC redetermination. The second level is the reconsideration performed by a qualified independent contractor. Moving on, you can see the ALJ hearing, that administrative law judge hearing by the Office of Medicare Hearings and Appeals. That's the third level of appeal. You can see on this flow chart, or this illustration from the flow chart, I actually did a screenshot, that there is an amount in controversy for the ALJ hearing. It shows here that the amount in controversy is equal to or greater than $180. The next fourth level of appeal is the Medicare Appeals Council, and finally the fifth level of appeal is the Federal District Court, and the amount in controversy for that is greater than or equal to $840. And again, remember that this is for 2024. CMS has recently updated it. The link here on this slide will take you to that newest version. Now, the next portion of today's webinar focuses on data. That's what I advertised. I used a tool that we call the data dashboard, or the claims dashboard, to pull the data that I plan to share with you today. That data dashboard is an interactive tool that was designed by our data analysts in our Insight department, and Insight is the name of the unit at WPS that's responsible for mining data, looking at data trends, among other tasks and responsibilities. Now, there are different ways for people in outreach like Tom and I to pull that data or review the data. We can, just in a click of a button, review rejections. We can change it by that click of a button to denials. We can drill down by state and even at a county level. The dashboard shows rejections or denials by reasons, by codes, or even by specialty. And that's what I did today did in preparation for today's webinar. We can also use that dashboard to view trending, and trending alerts us to those increases or decreases, those things that might require education. So I want to talk a little bit about the data slicers. I have made updates to the slide to show that the data that I looked at today is even newer than that shown, those dates in the slide deck. I am looking at submission dates September 1 of 2024 through November 30 of 2024, and the data was last refreshed on December 16 of 24. So the data that I'm sharing is all specialty 25 submitted claims for jurisdiction 5 and jurisdiction 8. That means Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan collectively. Now, while the dashboard does allow us to drill down just by one specific state or even counties, I pull data for our entire jurisdiction. Now, there may be some of you wondering, well, what is a specialty code? I keep talking about that 25 specialty code. Specialty codes are designated, self-designated by providers, by most providers during the enrollment process. They're 2-digit codes, and while a provider can designate a secondary specialty, it is only the primary specialty, the one self-designated, that is used during initial claim processing. Now, there are some situations where a provider will request an appeal. They'll stipulate their secondary specialty for Medicare to make payment. Now, specialty 25 is the 2-digit code specified by CMS to describe physical medicine and rehabilitation providers. So we're looking at only those claims submitted by physical medicine and rehabilitation providers in WPS jurisdictions. It's a 3-month time frame of submission dates. And again, the data was last refreshed on December 16. And what that means is that any claims submitted for those dates after 12/16 of 2024 are not included in the data that I'm about to present. So here then, just as I advertised, I'm revealing the most common reasons for Specialty 25 claim rejections for WPS providers. The first, or the most common rejection, is that the authorization number is missing, invalid, or does not apply. I will be talking in just a little bit about how you can avoid these specific reasons for rejections, rather. Another common rejection, I caught myself there, it's a rejection, not a denial that I'm talking about, is the claim must be submitted to the Railroad Retirement Board, not to WPS. If the beneficiary is a railroad retiree, their Medicare claims are processed by a specific Medicare contractor, not WPS, but by Palmetto GBA, the railroad contractor. Another common reason for rejections is that the facility, lab name, or address or PIN is missing. Another common rejection is missing, incomplete, invalid name, strength, or dosage of the drug billed. And lastly, missing, incomplete, invalid ordering primary identifier. Claims that are submitted to Medicare do require the ordering provider when you're billing a diagnostic service or for other services. You need to be aware of those guidelines of when you do need to include that ordering provider ID on the claim form. I thought it would be interesting not only to see the top rejection reasons, but to also take a look at the codes that are most commonly denied or rejected by Medicare. And right now we're talking about rejections. So these then are the top rejected codes or rejections by code for physical medicine and rehabilitation providers. The most commonly denied, or excuse me, rejected code, I'm catching myself here, is a 99232. Well, why is that code rejecting for WPS claims? The number one reason is the claim must be submitted to the Railroad Retirement Board contractor. That is Palmetto GBA. Claims for co-workers are submitted to the United Mine Workers of America. That is the second most commonly reason that 99232, the subsequent hospital care, including moderate medical decision making, is being rejected by WPS. The third reason, the claim has been forwarded to Palmetto, which is the Railroad Retirement Board contractor. This is just an informational message that appears on that remittance advice telling you that WPS has already forwarded that claim to Palmetto. There are some situations where we will forward a rejected claim or denied claim information on to another contractor. It depends on the partner's trading agreement that they have with Medicare, which tells us which claims we have to forward on behalf of Medicare. So in this case, the claims that must be submitted to the Railroad Board, some of them are being forwarded by WPS, some of them are not. It depends on that trading partner agreement. 99309 is the next most commonly rejected code for this specialty. That's a nursing facility care code with those with high complexity. These are being rejected for your specialty because the facility name, lab name, and address or PIN is missing from the claim. So what you'll need to do, because this is another rejection reason, is fix it, resubmit it. The claim must be submitted to Railroad Retirement Board is also a common rejection reason for this code. And another is that the place of service conflicts with the procedure code. You need to make certain that the place of service that you're reporting on the claim is one that's compatible with that CPT or HCPCS code that you're reporting. 99214 is an established patient office visit, and it's rejecting for your specialty because there is missing, incomplete, or invalid billing provider primary identifier on the claim. Maybe it was keyed wrong. Maybe it wasn't there. Maybe you just simply transposed a number when placing that primary provider primary identifier on the claim. Another common reason for rejection of this particular code is that the patient insured's MBI and name do not match. The Medicare beneficiary identifier and name on the Medicare card have to match the information you're placing on the claim. Facility, lab name, and address or PIN missing is also popping up as the most common rejection reason for this code. The next one is interesting because I've done a number of these webinars for various specialties already, and it's not very often that an NOC code or a not otherwise classified code is popping up. 99499 is a not otherwise classified code that means unlisted evaluation and management service. The top reasons this is rejected is missing, incomplete, invalid billing, provider primary identifier, invalid or missing modifier, and facility, lab name, and address or PIN is missing. So interesting that that NOC code popped up for specialty 25 claims. Another common reason for rejection is the 95886. That's the CPT code, rather, that is. This is the nerve conduction study or electromyography. This is popping up. 74 of the 148 rejections. I neglected to tell you that I placed the number of rejections for claim lines along with these CPT codes on these slides. But of the 148 rejections, 74 of them were because there was a missing, incomplete, or invalid ordering, not billing. There needs to be a correction here. Cross off billing, replace that with ordering, provider primary identifier. So no ordering provider on the claim, or it was missing, or it was incomplete, or even invalid. Maybe it was an invalid primary identifier that was reported on the claim. What you need to do is fix it and resubmit it. Another reason is this is rejecting is that the claim must be submitted to the railroad board. And I need you to cross off that second bullet. One E&M code for the service level covered per course of care is not applicable to this code. Okay, so you can cross off that second bullet. So again, 74 of the 148 rejections for this code was because there was no or was an invalid ordering provider number on the claim. Now, I talked to you earlier about the kinds of data that we can look at, and mentioned to you that we also look at the trending. I mentioned to you that claims for retired coal workers should be sent to the United Mine Workers of America for processing. Instead, for the data that I reviewed and analyzed, there was 104 rejections during those current months, those 3 months that I looked at. But there was only 82 the prior 3 months. So there was an uptick here, a 22 claim increase, 27% change. So as we look at this trending and we look at the reasons why rejections are on the rise, we need to determine what we need to do to educate our provider community to avoid those in the future. And one way that we're doing that is by hosting this webinar today. All right, I talked about claim rejections. Now it's time to talk about and reveal the claim denial reasons for specialty 25. This is 24 there, that should be 25. A lot of fixes here, and I do apologize for them. And I want to point out that very first bulleted item here, duplicate charge paid, month, day, year, or that represents the date, and that date will actually show on the remittance advice, and the claim ICN. So it's going to tell you we've already paid this for this service on this day on this claim. 1,827 rejections within that 3-month time period. And that's only one form of a duplicate denial. Sometimes things deny as a duplicate because there's a claim currently in the system that is a duplicate. Sometimes there's there are other types of duplicate denials. If you go down the list, I'm showing you the top 5 for each of these during this webinar, but there would be more. And if you kind of think about those denials actually as dollars. It's a lot of dollars being spent processing duplicate claims. This represents, a financial loss to not only the provider, but to the Medicare program too. If Medicare provides education to a provider about duplicate claims, and the provider doesn't fix that, uh, it it could be considered fraud. Billing duplicate charges is an abuse because it does make, result in payment for services that shouldn't be paid for. Continued submission of these types of claims could be considered fraudulent if it's not fixed. If you use a billing service and they bill on a cycle, every month, every 30 days, send a new claim if you don't have in your system or in your records that payment has been made, you need to tell them to stop doing that. You also need to stop doing that if you're doing it within your own organization, of course, but we need to continue educating providers that submitting duplicate charges is not appropriate. The next top denial is collection of fee-for-service during periods of managed care. That one's a little cryptic, but I did verify what this means is that beneficiary, for the claim for that beneficiary is a claim for a beneficiary who has elected a managed care plan or a Part C plan, a Medicare Advantage plan. So the claim is denied then by WPS because it should be paid for by the Part C plan. The physical therapy or OT limit has been exceeded, 745 denials. I should mention to you that before we educate a provider based on these rejections and denials, we do look to see that it is appropriate that the service is being denied. In this case, we know that physical therapy providers, occupational therapy providers, those specialty 25 providers are submitting those services over the limit, or that they've already met that limit for physical therapy or OT, and that services are going to correctly deny because that limit has been exceeded. The physician or supplier is not eligible to receive payment, 694 denials during that 3-month period. This would be one of those eligibility type denials that I mentioned to a little bit earlier. And I'll share with you some fixes for that a little bit later on in the presentation. Another very popular denial, not just for specialty 25 providers, but for other providers, is that the time limit for filing the claim has expired. And this is one of those exceptions, folks, where there is no appeal right. So time limit for filing claim expired, no appeal right. Here are the top denied reasons by CPT code. 99232, of course, is subsequent hospital care. Denials because the collection of fee-for-service during periods of managed care. Claims should be processed by the managed care plan. Expenses incurred prior to coverage. So you would need to check the eligibility or find out when coverage applied for that particular beneficiary. Duplicate charge paid already on another claim on another day. I mentioned duplicate charges to you, and take a look at the very next code, 99214. That's the established office visit. The top reason that 99214 is being denied for specialty 25 claims is because it's a duplicate. That means there's a lot of claims being submitted, and I think sometimes it's providers need to do their due diligence and check why claims are denying, not just resubmit the claim. If we deny it the first time, it's going to deny the second time. So don't just resubmit a claim if your service denied. Take a look at why that claim denied. You can do that by using SNAP, the Secure Net Access portal. If you look under the claim details, look at that claim line. Most often, when you're using that self-service tool, there's going to be a more information button that you can click on that will provide even more and greater details about the reason for denial. Second reason 99214 is being denied is managed care plan. And this is a new one. Claim must be sent to an employer group health plan first. In this case, that would mean that this is a Medicare secondary payer situation, and your claim needs first to go to the employer group health plan before Medicare can process. More common denials by CPT code 99213 is your subsequent office visit. Very, very similar to those on the previous page. Duplicate charges, collection of fee-for-service during periods of managed care, and this physician or supplier is not eligible to receive payment. That means whoever submitted that claim is not eligible to receive Medicare payment, or else it could mean to you that something was just simply entered on the claim wrong, and you have the wrong provider on the claim. So you would need to take a look at eligibility, make sure that everything is keyed right on that claim, placed in the right position on the claim or in the right item or field, if you will. 20610 is the CPT code for an ejection of the joint or bursa. And again, here comes those duplicate of charge already submitted. The second most common reason for denials is that the time limit for filing the claim is expired. There is no appeal right for that. And then the next one is kind of odd. This is not a covered telehealth service. So apparently, this code was submitted by Specialty 25 providers during that time period, and they indicated a telehealth place of service instead of the correct place of service. So correctly denied. It's not a covered telehealth service. You would need to make that fix. So I told you the reasons for top denials for Specialty 25. I want to take a look at just one more code here before I move on. It's the 99309. This code is being denied. Caught myself again. Fee for service during periods of managed care, expenses incurred after coverage terminated, and routine services and related services are non-covered. Trending, Specialty 25. Here is an example for you. For this one, I chose a SNF episode of care. SNF is skilled nursing facility. Episode of care notice has been filed for the patient. This means that you're submitting a claim to Part B for services that should be reimbursed based on SNF consolidated billing rules and such. So 20 claims denied during the current 3 months, 14 the prior 3 months. This was a 6 claim increase, 43% change. And of course, as you'll see later on in my presentation, we have a lot of great resources available to help you avoid this kind of denial, those that pertain to SNF consolidated billing. I know we have some great videos on our YouTube channel. Of course, CMS has publications on their website and so on and so forth. So I'll show those to you as I'm passing by the long list of resources available for you. So we talked about fixes, and we talked about when you need to appeal versus fix it and resubmit it. So the next portion is how to avoid those rejections. That's, fixes means that you need to fix it, resubmit it. So modifier issues, make sure that any required modifier is present. Modifiers, some modifiers are applicable for only certain codes, so you need to make sure that your modifier matches the procedure code. And of course, you need to make sure that your modifier is valid for the date of service billed. Now, out on the WPS website, and I'm going to pull that over here real quick, we do have modifier fact sheets available. I am going to do a quick search of modifiers. There's different ways you can go to this. Of course, you could navigate, in which case you would go to the topic center and then claims and then modifiers. I'm a searcher, not a navigator, so I like to use the search function. Out on our website, we have many fact sheets for modifiers. When you take a look at these fact sheets, you'll see a description, you'll see appropriate uses, those not appropriate uses for particular modifiers. Some of these modifiers have procedure code ranges that match or that, that you can report that modifier with, and some have even more information. So that's where you can find information to fix those modifier issues. Moving along, we have authorization number issues. Now make sure that you're verifying that the procedure code you're reporting is one of those that does require the authorization, and you should not submit that Part B claim until the Part A claim is submitted. So it's quite possible your claim is being rejected for this reason. It did hit as one of the most common errors. For your specialty, we have, again, multiple education resources available to help you avoid this type of rejection. I'll show those to you in a little bit. They're on the list of the resources that I've included in your presentation materials today. Patient eligibility fixes, make certain that patient name, MBI match. Make certain that you're reporting that MBI correctly on the claim. If the patient name on their Medicare card has a middle initial, make sure that your claim has that middle initial. Make sure that you're sending claims to the correct payer. I talked a lot today already about Railroad Retirement Board, United Mine Workers of America, and Medicare Advantage. Those services, our claims are being rejected, many of them for Specialty 25 providers, because the claim is simply being sent to the wrong payer. Provider number fixes, verify that you entered the information right, that there's no keying errors. Make certain that your rendering provider on the claim is associated with the billing provider. You would need to check your provider enrollment records to verify that. And if the service you're billing requires an ordering provider ID, make certain that you're entering that ordering provider information correctly on the claim. Now we're talking denials here. Avoid duplicate denials. Don't automatically resubmit prior to establishing the payment status or the status of that service. Do your due diligence. Don't just resubmit automatically on a cycle. Make certain you're billing appropriately. Sometimes you can use modifiers that tell Medicare that this is indeed a repeat service on the same day. So check out those modifier fact sheets and make certain that you're using the appropriate modifiers to avoid those denials. Avoiding MSP denials, verify whether your patient has insurance that is primary to Medicare. That's item number 11 on the paper claim that you fill out. And of course, if you're like most providers and submitting electronically, you're going to want to make certain it's reported in the correct field on that electronic claim. Let me show you a handy tool that will come in handy to avoid those types of denials. Or to make certain that you're submitting things in the right place on your claim. I am going to the WPS homepage of our website. Under quick links, there is EDI, Electronic Data Interchange. On that, scroll down the page and choose Medicare EDI. We're talking Medicare today. And if you scroll down this page, you will find links to some helpful information that our EDI staff has prepared for you. I talked earlier on in my presentation about the companion guides that help explain the data elements that you need on claim submissions. That 276, 277 companion guide, you can find that and other companion guides by choosing this link. But here under Medicare resources is this crosswalk. I mentioned just now the fact that you need to fill in item 11 on your claim in order to tell Medicare whether there is insurance that's primary to Medicare. This is that crosswalk I talked about, and it goes item by item in this left-hand column. The item is the number on the paper claim. So if it's item 11 on the paper claim, where does that information need to appear on the electronic claim? And that information is also available on this crosswalk. Okay, so here's the loop. So this is the crosswalk that tells you if it goes in item number such and such on the paper claim form, where does it need to go on the electronic claim form. Another thing that I like to point out when showing people this particular tool is the status code column. You'll notice that some show S. There are some that show R. That is explained at the bottom of each page of the crosswalk, and R means it's a data element that's required in order to process a claim, meaning if it's not there, it's going to reject. S is situational, any data element that must be completed if other conditions exist. So that's just kind of another handy tool to avoid some of these rejections for claims. Right, back to the PowerPoint. Here are some resources, and I mentioned to you that for some of these resources I'm just going to touch on. The expectation is that you can come back later to this information, open these resources, and find the information you need to to fix or avoid rejections and denials that I've talked about here. We have the MSP fact sheet, questions and answers. CMS has an MSP web page, and of course I mentioned earlier to you that our YouTube channel has a lot of instructional videos. We even have a playlist for Medicare secondary payer, so that I've included for you. Avoiding E&M denials. Now, some of those were hitting the, based on the data, their top rejections or denials for your specialty. Now, for those claims that are denied, you are going to want to take a look at the Evaluation and Management Services Guide. I've linked to it here on this slide. It's published by CMS, has a lot of great information, tells you what you need to know in order to establish whether it's a new patient versus an established patient. It also addresses global surgery periods, concurrent care, and other E&M things that wouldn't likely be so important to your specialty, but some of you might also work in other specialties as well. So that E&M guide has just a lot of terrific information that will help you code and submit evaluation and management services correctly to Medicare. And of course, we do have an extensive playlist for E&M videos available out on our YouTube channel. Sorry about that. Avoid the timely filing denials. Make sure that you're submitting your claim within 1 year of the date of service. This, folks, is that exception that I talked about earlier that does not have an appeal right. This type of denial, timely filing denials, do not have an appeal right. Some of the common rejections that we see or common reasons for timely filing is that the primary insurer already paid in full, so no claim was submitted to Medicare. We do have some great information on our website that speaks to this, and we've also done some, we've also hosted some webinars. Get back here. I want to pull this over. Bear with me here. I'm trying to pull this over. All right. Move too fast. Here we go. Timely filing. I want to show you where you can find some information about this. Timely filing of claims. I simply put the word timely in the search box. Of course, you have the link to it in your presentation. But here's our information on our website that pertains to timely filing. This talks about the claims that have been denied due to timely filing. They don't have appeal rights. CMS in their internet-only manual, and we've cited it here, we provided a link to it, says that third-party payer errors in making a primary payment determination does not constitute good cause for purposes of reopening an initial determination or redetermination, and provides you, of course, with the link to that information. That's one of the top reasons or the most common reasons why claims are denied beyond timely filing limits is because the provider thought someone else was responsible or already made primary payment, and then they come back even sometimes years later and recover that money. If you didn't submit a claim to Medicare timely, CMS says that we can't reopen that claim for that reason. Now, if you do have a potential reason that may extend that timely filing limit, this particular resource on our website tells you how to file a waiver to extend the timely filing limit. So some great information. Of course, I opened for jurisdiction 8 here. You could see that that's highlighted up here, jurisdiction 8 MAC. If you're Part B MAC and needed information, just click on Part B MAC. And it will show them the addresses for our J5 MAC states, that is, not Part B. J5 Part B versus J8 Part B. Sorry about that. Tongue-tied there a little bit. All right. Okay, back to the PowerPoint. Timely filing. It's problematic, has been, will hopefully not continue to be. We're doing a lot of education on that. National Correct Coding Initiative, edit denials, some of those were popping up. I know I didn't talk about those extensively today, but I did want to provide you with some resources so that you can avoid those if you are receiving remittance notices with those types of denial. We're talking about those medically unlikely edits or procedure to procedure edits, bundling. This would be bundling, or when services are denied because they exceed the medically unlikely edit amount that's published, or some of them are confidential, they're not all published. But in order to use these tools, you can use this very last bulleted resource here, how to use the Medicare and CCI tools, if you need instructions on that. More resources and tools. Here are claim form requirements for Medicare. You can find those in publication 100-04. Chapter 26 is the paper claim form. We do have that crosswalk that tells you, if it goes here in the paper form, where do you put it on the electronic form? Rejections. These are we have this resource on our website. It's called How to Correct a Rejected Claim. You can see a screenshot of what that page looks like. When you go to our website and you go to this resource and you scroll down, you are going to see those reason and remark codes that appear on your remit advice. If your claim is rejecting, look for the reason or remark code in this resource, and that will tell you what you need to do to fix it and resubmit it. Similarly, we have a resource called Common Claim Denials that does the same thing. It lists the reason or remark codes, but only this time we've categorized the denials, bundling denials, duplicate denials, so on and so forth, provider number denials. We talked about those earlier when I gave you those examples or revealed those reasons for denials. This will provide you with or suggest actions to take to avoid those most common reasons for denial. Here are other WPS resources. I talked about the website today. Live events webpage is going to tell you about future education we have offered. When you complete the survey that you'll ask to be complete at the end of our presentation today, you'll be able to tell us suggestions for topics in the future. Encore presentations include links to those recordings of our webinars. I have this one, Billing and Describing Not Otherwise Classified Codes. This is a resource on our website that speaks to what you need to place where on the claim when you are billing for an NOC code. NOC code popped up in this webinar today based on the data that I analyzed that talked about rejections and denials for Specialty 25. YouTube channel, whoops, I scrolled too quick here. YouTube channel, I mentioned this several times today, those playlists. We have Medicare Advantage playlists, E&M playlists, and even more. CMS provides some great resources as well. The Medicare eligibility or checking Medicare eligibility fact sheet will help you accomplish that, those eligibility checks. Remember, if you are a registered user of SNAP, the Secure Net Access Portal, you will be able to check Medicare eligibility information using that self-service tool. This Review Contractor Directory is an interactive map out on CMS's website. You can click on any state in that interactive map, and CMS tells you Where do you send claims if the beneficiary is a railroad retiree? Where do you send claims to the MAC? You know, it provides all that contact information for the various contractors specific to a particular state. So that interactive map will be helpful in helping you determine where you need to send your claims. The IVR is where you can find claim status and details 24 hours a day, 7 days a week. There is limited functionality outside our business hours. This is that self-service tool. You can use voice or telephone keypad. We do have instructions for its use in our operating guide available on our website. I've talked about the SNAP Secure Net Access portal several times today. This is where you can log in once you're registered, check eligibility, look at claim status, look at claim details, use that more button or more information button that tells you more information relative to that particular claim line denial. Again, 24 hours a day, 7 days a week, limited functionality outside business hours. We do have that portal user manual out on our website. I'll show you real quick. You can link to that portal user manual from our home page right here under the login button, or the login button that appears on our web pages. And also, if you scroll to the bottom of the page, right here is the link to our portal user manual. Again, lots of great information there. This brings us to time for questions and answers, and unfortunately we are at almost end time today, so I am going to move on past a live Q&A and suggest that you send us your questions, and I'll tell you how to do that in just a moment. I will send an email response to you if you have questions regarding any of the information that I have talked about today. And I believe Tom has already placed information into our chat how you can ask a question. If there is a question that you've already submitted out into our chat, I will make certain that I answer those as well. Just a lot of information to share with you all in this particular webinar. No time for live questions and answers today. If you are seeking or you need continuing education units, in a few minutes, you are going to receive an automated email. It's from WebEx. It's going to thank you for attending. If you need CEUs, do not delete this email without reading it. This email is going to contain your actual certificate of achievement. It's going to look like what you see on your screen. It's going to have your name, contact hours, and the name of this event along with today's date. This is what you will need to turn in to a governing body in order to request credit towards continuing education units. If you don't see it, check your spam or your junk folder. If you do find it in spam or junk, make sure to add the WebEx email address to your safe sender list. If you join by phone today, you will not receive the automated email from WebEx that thanks you for attending. But if you need a certificate of achievement, send an email to our education mailbox, include today's date, the name of today's webinar, and the telephone number you called in from. And after we verify your participation, we'll send you a certificate of achievement. You can find the education mailbox address in the chat. Tom's placed it in there already a couple of times, probably today already. If not, right here at the bottom of the slide, at the very bottom, you can find the address to our education mailbox. And also on this slide. This slide is where I talk about those questions, your follow-up questions, those questions that you may have submitted into chat. If you think of any presentation related questions, or if you submitted one already in the chat that I haven't answered, you do have 1 week from today to submit them. Send them to our education mailbox. The address is here on this slide. And put the webinar topic title in the subject line. The staff that is opening that mail will send your mail over to me, and I will be able to respond to it. Now remember, claim-specific questions must be sent to customer service. It is staff in that department that has access to the actual claim information that needs to be looked up to respond to those claim-specific inquiries. Staff and provider outreach, like Tom and I, we do not have access to those specific claim details. Please take a few minutes to complete a brief survey to tell us what you liked about today's webinar, what we could do better, suggest topics for future education. Your feedback really is invaluable, ensuring education that we provide is timely and effective. The survey is so important that we're going to give you another chance to complete it later when you exit the webinar. You'll be redirected to the CMS Qualtrics page for the survey. The message that's going to pop up is going to look similar to what you see here on this slide. It's the little picture with the yellow triangle at the top. If you have not already completed that survey, please use the opportunity to do so. There's also a link built into your presentation materials today. CMS is looking at these. We are looking at these, not a single survey goes or comes in that doesn't get looked at and attended to. So please give us your feedback. On behalf of myself and Tom and our entire provider outreach and education team, I do want to thank you for your participation. I know everybody is very, very busy these days. We do look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everybody.